I um, want to talk about something that is, I think, difficult to talk about. Um, uh, and so I will try to be careful and gentle and make the argument plainly. Now, it is difficult to talk about in large part because it's a good thing to do trials. And it's a good thing to have even more trials done. Um, and when something is good and you need more of it, it's hard to then say, don't do it, or it may be bad in this situation, or it is bad in a lot of situations in which it is done. Um, that's a difficult, tricky thing to talk about. So I will try and then talk about how I approach it, especially in the classroom when I teach. So the slides I will be using today are in fact slides I use in my classroom at the University of Sydney to explain what this thing is. Because I often feel that it is important to get students thinking about trials in health systems, about complex things in this way early, so that they are, I often say, immunized against all the other forces that may make them want to do otherwise. And those forces are real. On the one hand, and I'm using Rashida's arguments here, on the one hand, trials they are often presented as the high water mark of biomedical research. And it is for biomedical research, but not for other things very often. Journals want to publish them, careers are made on the back of them, and so they are attractive and they exert a strong pull for people to do them. Um, and in places and situations where trials are done extensively, they then become a force by themselves. That there's a whole ecosystem built around them. That is that then hard, if not impossible, often to ask other questions, even if other questions are necessary to be asked. And often, again, not always, often those other questions are questions about things that sit upstream from the questions the trial may want to ask. Now, so I say this as a preamble to what I'm going to talk about, which is then how do we then approach, in fact, offering caution, offering explanation, offering reasons to think and do otherwise, when in fact, a lot of the other forces in the ecosystem which you operate make us want to do things in a particular way. So my explanation it's twofold. One is a zoom out explanation, and the other is a zoom in one. The zoom out one is looking more broadly to say sometimes the problem is not a specific trial. Sometimes the problem is that the trial has been dropped into a knowledge landscape in which a lot of other evidence, often perhaps even more important evidence, is missing. And how do we go about figuring out what is missing? Because most of the time, a lot of the time, what we want to do is not say, don't do the trial. It is to say, what is the priority here? What other questions, what other needs are present in this place that we need to attend to before, alongside, in exclusion of the trial. So first, how do we begin to even approach that particular question? And I like this line from Kurt Lewin, whom I think was a sociologist, who said this line that I love to repeat to my students, which is that there's nothing as practical as a good theory. So if you look at an ecosystem, a health system, a particular place, and you want to figure out what is missing, you have to have an idea of the range of things that could be there. Otherwise, you can't begin to detect absences. And that is how we do things most of the time. That's how a Sherlock Holmes will approach an investigation. You have a theory of what should be there. What data should be there that's not there, what evidence should be there that is not there. What was produced and what was not produced, who produced it, and for which audience, for which reason, for which purpose. Um, And in the midst of all of that, I'm also asking the question, um, what is the relationship between the knowledge producer and the audience for which it was produced? Um, Again, because often in these systems are complex systems by definition. And anything anyone says about a complex system will reflect where they stand in relation to it, but also who they think is within earshot or whom they are addressing that thing they have to say to. Now, those things will be far more important, will say far more about the person and whom they are talking to than will say about the system itself. Which is, again, one of the ways in which I approach this question of, okay, I see a trial done, and I'm asking myself, why has this been done? And often the answer to the question, why has this been done, may be found in how the person, the people who did the trial, how they stand in relation to that system or that reality or that group of people, and whom they think is listening, whom they are trying to impress, whom they are trying to influence, whom they are trying to address. Now, I indicated earlier that whom they are trying to address is often um, uh, a journal that will publish it or a career need that it will serve. Um, but often, whom they're also trying to speak to is an imagined powerful policymaker who is waiting, supposedly, for that evidence to act. Um, Now, sometimes that is true. Most of the time, it is about if it is about a complex social thing, it is not true because often policymakers know what to do in a complex system about a complex thing, and a trial will not likely not change their mind if we are being honest. Again, I'm talking about complex things. I'm not talking about trial of a simple thing, and I'll get to that in a minute. And so when I'm wondering what else could be happening here, I'm wondering what are the needs of other actors in a system that are not policymakers? Um, what are the needs? When I say needs, I mean the knowledge needs, the evidence needs of other actors in the system. So in my head, I saw the actors into four sets of categories. One are fellow academics, and I put in that category, say, perhaps journals. Um, Policymakers are another group. What are their real needs? Is it really that trial that they are waiting for? Or, in fact, should they be the primary target of the evidence generation? Might it be practitioners of all kinds in that system? Might it be activists or advocates in that system? And so again, when I see a trial done, I'm often asking myself, who else has knowledge needs in this ecosystem? And what is the intellectual investment in addressing those people's knowledge needs in relation to the knowledge need that that particular trial is addressing? And that is how I often come to a conclusion, not always, but often, that perhaps the resources spent, the energy spent on that trial may have been far more consequentially invested. Um, And again, yes, so I'm thinking about who is producing and for whom. And this matter to me, again, because many of us who are in a position to do the work of knowledge production and evidence generation, we exist in situated ways. We are positioned in particular ways within systems, and we often are positioned in ways that actually mean that we have power and we are removed. And if a lot of the evidence we produce, or if the ones that in fact are most attractive, glamorous, regarded, are the ones that we produce to have a conversation among ourselves, or to impress one another, then there's also something happening by that measure, which is that there are people and actors less powerful than we are, far more proximate often to the situation than we are, whose knowledge needs we are ignoring, or for whom their knowledge needs receive significantly less intellectual or other resources than we put to the service of the things that we care about. So that's
Hey,
the first.
hey,
Yeah,
can I just
yeah.
interrupt for 1 second? You're still on the first slide at the moment. Are you? expecting to have
No,
advanced the slides.
I've moved the slides a lot. Oh wow, okay.
Ah, okay. Is it just me or and Di, are you seeing the slides moving?
No, they're not
No,
moving. Now
and that
yeah, we
Okay.
were all on the first slide.
Okay. So we've been watching the first slide. So
Oh wow, not
thank you
good at
very
all.
much. I'm really
Is
sorry
it
to
moving now?
not have told you sooner.
yes, now it's moving.
Now it's
Thank
Okay.
moving
you.
fine.
Okay. So I'll just talk through everything in like a minute so that you see what
Yeah,
I
a
thought you were seeing.
quick
Um,
rerun.
yeah. Um, so this is where I talked about being a detective and being at a scene of something and trying to figure out what else should have been there in terms of knowledge
Yep.
production. And I used that quote from Kurt Lewin. Um, and then this is where I was talking about again the crime scene and what else. How do you begin to figure out what is absent, what is present? And I talked about the elephant. I thought you had seen this elephant when I mentioned elephant. But this is a familiar, popular metaphor, parable that is used to describe how what we see often is a function of where we stand. But I often stretch that further one step to say what we say is, or in this case, the knowledge we produce. It's not only a function of where we stand, but whom we think is listening. So what the audience is, because the audience is a powerful co-creator of knowledge that we produce within systems. And then here I was talking about different categories of actors in a system. We talked about how we often direct our attention to fellow academics or the things that make us happy and impress us. Or perhaps we have a theory in our mind that there's a policymaker who might call engineer in this framework, who is just waiting for that evidence and something will happen, which is often, very, very often not the case. Which then, of course, should make us ask ourselves, what are the other knowledge actors in the system whose need we may be serving? And whose actions may be more consequential than the ones we often have theory in our mind and our head, is in fact the biggest game in town. So I'm thinking here about activists, advocates, community organizations, community groups whose knowledge needs often receive significantly less intellectual resources and attention from us. But I'm also thinking about practitioners of all kinds who also have knowledge needs in the system. Um, and so I was wrapping that half up by making this broader point about how if we are not playing that exercise that I've just described, we will often find ourselves only speaking among ourselves about the things we care about. And we will likely find ourselves in that process disregarding other important actors, sometimes even far more important actors in a system whose role involve knowledge needs, who interpret knowledge, who use knowledge, who are legitimate audiences of knowledge, and whose needs deserve our attention. So that was the first half of what I was going to say, which is just to give a zoom out and not focus on the particular trial itself, but the ecosystem within which it happens, and what other things we should be asking for when we see a trial being done, when we're invited to do a trial, or we find ourselves, even assessing, evaluating, critiquing, appraising a trial. Now I will go to the zoom in part, which is the part where I actually then look specifically at trials, or at that which may be evaluated. Let's not say trials, a thing that we may want to evaluate or assess or understand. And in this, I often use these four dimensions, but five sets of images to drive home my point. Now there's the point, which is zero dimensions, a singular point, no surfaces as it were. Then there is one dimension, which is a line. There are two dimensions, two surfaces. There are three dimensions, which is cube. There are four dimensions where sort of the cube sort of exists in sort of two states, which we may think of as temporal states, right? Or time shift, time difference. And this is a useful heuristic I've found to explain what I'm often trying to say when I'm saying a trial doesn't make sense for a particular thing, or that it makes sense for a particular thing. It's a useful way to explain what I mean when that is going on. For example, when what I'm thinking about is something of zero dimension or a singular point, I'm thinking of something as simple and basic as, say, a drug, a paracetamol, for example, or even a drug that is more than one drug, a cancer cocktail or something, for which the best way to evaluate it is to do a randomized control trial. Because it's simple, it's basic, it's consistent. What it will do in Lagos, it will likely do in Nairobi, it will likely do in Rome. Because human physiology is sufficiently consistent, the drug itself is robust in its consistency, in that it will have the same chemical composition in all those three places. That you can afford to imagine a way what I described as pose. Because of course you are standing in roughly just one position in relation to it. It doesn't have multiple dimensions. I can also assume very often a neutral audience, in that an audience is not likely to be so invested in the result that you change what you see or say. Now that's what's possible, but in exceptional cases. So it's reliable, simple, singular dimension, pose and gaze, can hold them in place, do a randomized control trial. You move to something that has, one dimension. And here again, I'm thinking about something that is a bit more complex than paracetamol. I'm thinking of a device, like a surgical implant. Now, a surgical implant, again, you can assume, for all intents and purposes, it's like a drug, in that what it looks like in 3 different cities, in 3 different continents, it's likely the same thing. Now, of course, with an implant, you are introducing an element of variation or variability in the procedure through which you administer it. Right? The surgeon who does it, the training they have, the conditions under which it's done, etc., can introduce significant variations. But still, you're evaluating the implant. You can standardize largely, broadly, the training, such that, in fact, I will still say I need to see a randomized control trial evidence before I accept that this thing does that which you are claiming that it does. Again, to the extent that there are different positionalities around it, maybe 1 or 2, simple enough, basic enough, you can control for that. I can often assume, again, like for paracetamol, a relatively neutral audience. Now we move 1 step further, and we have something that is of 2 dimensions. So that's 2 moving parts. There's a surface, 4 points, 4 edges. Things are a bit more noisy. And again, if it's an intervention, I'm thinking of something that's like a discrete social measure, like a fixed incentive, right? There are a few moving parts: the giver's mind or interpretation, the receiver's mind or interpretation. There are relations between them. That introduces a level of complexity, but still not so much that we can't pin things down enough to put it to an experimental, process, right? How does the incentive work? We can do game theoretic analysis, we can do social psychological experiments, and we can assume for the most part that human beings are relatively similar around the world, given similar circumstances, right? That we can try to abstract the effect and effectiveness and the mechanisms through which this discrete social measure, fixed incentive, works. Again, giving account of it, you can describe it from different positions, 3 positions: the givers, the receivers, the third party is an onlooker. Again, for the most part, these are things that you can hold down and control for, or even if they are different, highlight the differences, but still you're doing something that is sufficiently universalizable, right? And then we move to something with 3 dimensions. Now, here begins a lot of the things we do in the name of complex health and social interventions. It's a thing with, at least 3 moving parts. There are multiple services and multiple edges. When I say multiple services and edges, I mean actors, interests, dimensions, things going on around the thing or within the thing itself. Again, you can imagine an intervention that we call a loose social measure, the training of health workers, which again has very many actors involved. The training itself, the people paying for the training, the people delivering the training, the government that allows the training, the condition that it is allowed, the people who receive the training, etc. That we're dealing with the minds and interests of quite a wide range of people. We're thinking of resources which can be held down. We're thinking of relations which can be fully understood for the most part. We're thinking of reasoning that we have to approach carefully to begin to figure out that if we were going to evaluate something like this, the question that will be interesting and important to answer is not whether this thing works. It's something that is beyond that simple singular question, whether it works. The same way we might ask it for the surgical implant, the same way we might ask it for a drug. It loses a lot of meaning when we are dealing with something that is multidimensional like this. That even if we were to do a trial, it would almost need to be a trial that is set up to only serve the purpose of implementing the thing in a particular place. It would not be a trial that makes meaning for, say, if it was done in Lagos, it won't be a trial that makes meaning for Rome, something this complex. We're dealing with, again, something that is all over the place. So that the questions we want to be asking of this thing is, how does it work? What are the mechanisms active within it? For whom does it work in those places? Under what conditions does it work? And what does work mean for each actor? Because again, for each actor standing around this thing, work can mean very different things. The NGO, it works in a particular way. For the patients who will receive the care, given the training, it works. What work means differs significantly across the actors. That the posts around which we may be making evidence is noisy, really, really noisy. And so are the interests and the preferences and the power that the audience of that knowledge may wield on what we choose to generate knowledge about in relation to that. And then the next and final step in my heuristic is to think about something that's even far, 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 far noisier than that. So something that we have good reason to expect will change 1 month to another or 1 year to another. Say we have a performance-based financing initiative. It's an unbounded social measure in many ways. What a performance-based financing incentive does in a place will, for all intents and purposes, change over time. So that we have to think not just in terms of the thing, but also you have to think in terms of the temporal things, temporal features of the thing. So there are many moving parts. And it is also, for this kind of thing, we have to be thinking about how the system itself learns to deal with the thing, to figure out the thing, to change its relationship with the thing over time. So we're not just thinking about the resources and the relations and the reasoning of the actors, we're also thinking of how the actors themselves learn about, around, to support, to oppose, to drop, to spread, etc., this particular thing. So that, again, the kind of question we can reasonably ask about the effectiveness of this thing, or what effectiveness means here, is also hyper noisy, and will depend too much, very much, on who is doing it, where they stand, what their interest is, and you can multiply that by orders of magnitude, also with the multiple audiences interested in this particular thing. And where they stand in relation to it as well. Again, it's really noisy that if we have an initiative like this, the kinds of questions we want to be asking and the purposes for which we want to be asking those questions have to be clear enough to us. And what the moving parts are, what the surfaces look like, have to be sufficiently comprehensively theorized ahead of doing anything, so that we know what we are doing. And again, very too often, I find that these contours, these surfaces, these actors, this learning, these resources and relations and reasoning are very, very severely under-theorized in a lot of trials, which then takes me back to that point where I began, where I said, it seems as if trial, in that case, in many cases, is just a hammer that is looking for a nail. Like, we have this hammer and I have this tool, and I've been told this tool is good and it's great and it will get X, Y, Z. So I need things to look like nails. I want them to look like nails. Because if we are really approaching how things really are and respecting the complexity of things and complexity of context and the complexity of the relations among actors, then a trial would often be the last thing on our mind for a lot of the things for which it currently is the first thing on our mind. So again, I'm just showing that those 5 examples, and I'm going to stop there. Thank you very much.
Thank you, Seye, for laying the scaffolding of trials. And I have a lot of questions, but I hope that the audience will join in. So my first question really is that you mentioned that there are 4 different parameters: the dot, the line, the square, and then the cube, and then bigger.
Yeah.
I think that in academic architecture, we treat them really all the same. And linked to that is also kind of academic interests, that trials are the gold standard, and that they will be what is considered evidence, and that's what is needed. So and that plays into journals and the whole. So we are essentially serving one group. And the point that I've felt over the years is that we really then do not serve all the different gazes that you mentioned, despite the fact that trials vary hugely in complexity, from that could be a paracetamol trial, all the way that could be a trial of financing and very complex interventions. That speaks to academic architecture, but it also speaks to the fact that whilst we've got all of these ethical frameworks to safeguard and all of that, that doesn't quite cover it. So I just want you to comment on that aspect, and then I will ask for a couple of questions to illustrate some of these issues that we've come across.
There's a lot in what you said in like a minute
Yes,
or so
I know. I know.
But I'll start from where you ended, which is the ethical part and the ethics part. That again, almost all the trials I have big problems with were passed by some ethics committee somewhere, including trials that there's a whiff test, there's a pub test that people often say they didn't pass the pub test, and if you just it's hard to even begin to reckon with how an ethics committee thought this was sensible. There was a trial in Kenya a few years ago that was checking the effect of discontinuing people's water supply on whether they would pay their water bills. Poor people. And you ask yourself, so why are you doing this? Again, because, and they will justify it with all kinds of reasons. But the question I was asking is, where's the ethics committee? And they said the ethics committee approved it. So there's a lot that we need to do with how we think about ethics and the ethics approval. My sense is that we need to do a lot of this kind of consensus building work, that we have a broad set of agreements about what is sensible and what is unethical, and then we can take that to different committees. There was another point you made is about what is considered evidence, which is an important point, which again is a reason people often give for doing trials. And Rashida, you know how I feel very strongly about a trial that was done to see if eating food was good for people with TB in India.
Yeah.
Now, again, this is something we've known for at least 100 years. And even in the paper, you'd see that the authors themselves acknowledge that we know this. But when I've asked people close to them, some of whom are friends, the excuse is, the WHO wants a trial before they can change their guideline. So I'm asking, what is wrong with the WHO? And what is wrong with you for agreeing with them? So again, there's this issue of expectation, and it's also our job often to say to whomever is expecting this that this does not make sense. I had to ask, there was a South African with whom I was having a discussion defending this trial, and I said to the South African that if during apartheid someone asked you to generate evidence that giving Black children what white children had was good for Black children, will you then go ahead and generate evidence that says giving them good quality schools is good for them? If the government says we won't give them good quality schools without that evidence, will you then go and generate that evidence? And for me, these are the questions we have to be willing to ask ourselves. That at what point do we become, frankly, not thinking? Or do we feed a beast that the more we give to you, the more you will ask? And yeah, so there are all these serious issues that we have to be able to think and talk about.
Yeah, and following on from that, Seye, I think that, as you say, that we've held ethics committees and WHO, for instance, as a world policy body, as justifying trials, but also that trials are good and ethical to do by ethics bodies. I want to pick up on a couple of ethical questions that I grapple with. So one of them is the fact that you're doing a trial often with a comparator and not thinking enough about what the comparator is in settings where that comparator might not be available, but that comparator is standard of care in high resource settings, right? And we justify the need to do a trial because that comparator is not available. And it's a bit like, for example, wearing gloves, right? You would never do a trial of wearing gloves in the global north, but you potentially might. And I refer to a recent trial and potentially one that was presented at the aperitivo last time we drew this, is a trial where the intervention was about providing clean baby kits, antiseptic, and what we do, we justify it is by putting it all together. Like it was a kit, and that's why it became different. Whereas I don't know any professional, be it a doctor, a nurse, or whatever, who would not think that providing towels and kits and temperature monitors is an absolute minimum that we should give to women during childbirth. So I very much grapple with the fact that we justify interventions based on what is not available. And that again speaks to the epistemic injustice, because it becomes ethical because it's in a package or whatever, and again speaks to the architecture of policymakers and academia to justify why we're doing it. And I really want you to speak to that, because I did speak about that trial with you.
The question I often ask when such a trial is justified, that sort of brings things together in a package and says, we've never tested whether this package works, is if each of the things in the package is good, if the trial comes back and says the package is not good, will you believe the result? In other words, if someone says, we know that giving people food is good, or we know that giving children antiseptic, etc. is good, and then you do a trial and it shows that it is not good, will you believe it? And if you believe it, what would that say about you? In other words, there should be a test we should be willing to put ourselves and the things we put together too. And if it did not work, I promise you, the person who did the trial will come up with a very comprehensive explanation as to why it did not work. The explanation they could have come up with before the trial and would have frankly negated the need for the trial if it didn't work. And I've seen this happen in real. I wrote a long essay about one that didn't work. And you could see how after it didn't work, the people who did it suddenly realized that they can actually think about complexity and context. And they discovered that in retrospect, and they explained everything. And I was thinking, if you knew all of this, you wouldn't have done this trial. You would have spent your time and resources in a different way. So that's the question I'm often asking there. That at what point is this just an excuse to do another trial? Now, that said, if I was running, and I give this example, if I was running a district health department and I'm thinking of Nigeria, if I'm running a state government Ministry of Health, and I want to roll something out, I can design that as an experiment to learn how best to roll it out. Again, noted, I'm not evaluating the thing. I'm learning how best to roll it out in a particular geography. I can randomize. Do it this way here, do it that way, do it that way here. And then we're learning on the go. And then if it's working well, doing it this way, let's keep doing it that way. Let's pivot. If it's working that way, completely contextualized in a particular way, let's do that. In other words, I can see an experimental design making sense. But in that case, I'm not making any claim about external validity. I'm not making any claim about effectiveness. I'm learning. It becomes then a learning process, which is a completely different thing. So again, there are reasons to do things in certain ways, but you rarely find anyone doing a trial in the way that I've just described. That often it is to prove something that can be proven, that just doesn't make sense to even set out to prove.
Mm-hmm. Okay, and so then I think the question, as you said, it's setting out to prove something, which by definition needs a comparator.
Yeah.
And I think you've very much highlighted that, and I think this example highlights that comparators can be very problematic. And that also speaks to context, and a comparator that you may be available and standard of care in a high-income country, maybe not. And then the second thing, as you said, with your rations trial in India is finding an excuse for a public health outcome when the intervention, or I don't want to call it intervention, when that thing that we want to give somebody is a basic human right. So, for example, when you think about menstrual pads or when you think about food, do we really need to justify TB transmission or school attendance to be able to provide those interventions?
Yeah. And again, when we find ourselves needing those justifications, we already lost the plot. Or the people on whose behalf are making those justifications already lost the plot. If I need to convince you that creating a feeding program for children will make them come to school. If my argument is that doing so they will come to school, then we already lost something in there. And an additional risk of that is that we're also then legitimizing that. Because tomorrow, when another human rights entitlement is up, the government will have an excuse to say, remember, when I asked you to show me evidence, go and bring me evidence for this one too. There's a practice where I grew up called Arodo. If there's any Yoruba person in the room, they may know what I mean. Where if a child is being really naughty, the mother can send the child to her friend's house to go and get Arodo. Now, Arodo literally means stand still, wait. The mother's friend understands that and say, okay, wait for 30 minutes, I will get it for you. And then child waits for 30 minutes and doesn't find it, send the child to another friend's house. So go and get Arodo from Mama at this place. And then you go again. So, you've gone around for like 3-4 hours, you're back home, you're tired, you go to bed, you are well behaved. And often I feel that is what the game we are being pulled into. When these kinds of demands are made of us. Like, go and bring me evidence for this. And then you bring in and say, okay, go and bring me the cost effective analysis for this. Go and bring the budget impact analysis for this. You can bring it, and then things have changed in the last 3 years, so bring another one. that if the evidence is that which is really needed, I promise you, the demand will look different. Yeah. So yes, and to your point about comparator, it's such an important question. It's a big question. Um, there was a big scandal. I'm not sure how popular it was with a a cervical cancer screening test in India that was funded by the Gates Foundation. It ran for more than a decade. It was a big scandal at some point because the comparator that the group that did the trial chose was not what was standard practice, but what was available locally. Even though what was available locally was also changing because the government was investing more and more in what was standard, such that they held people in a fix, not able to access what was available, and the comparator was nothing for a very long time. And again, the question on my mind is, did we need that trial? Did we need to know if this thing works in this place? This is something that is very biological. If you're testing whether a testing thing works, you can't test it anywhere. If what you want is access for people who are poor, the trial is not the answer to your access question. It's a political question, it's an economic question that has to be asked and answered in that way. So again, I find that we conflate these things a lot, that we pretend or assume that a political question has a technical answer, and vice versa.
Right. Can I jump in? I would like to just say a brief word about the importance when you're thinking about studies. I'm not saying trial here, but studies is thinking about what the question is and how, and that's where you should spend an awful lot of time, in my experience, and actually go on the ground and find out what the question is there. Because you're talking about interventions as if they might work universally, and we know they work in different ways in different places, and that is really important to know. And then I think so you are really focusing on, do you need to do this trial or should it be? But you may want to do a step wedge trial. By that, I mean, design is really, really important, and it can be within a trial, or it could be that you don't need to do a trial, because sometimes you don't. And you have to say, I was thinking about, for example, when we were talking about doing trials of HIV testing in the UK, for example, well, we know the test is very good, you should, that actually there is a benefit to offering it to pregnant women. So why did they fund a trial to look at testing in Scotland, for example, when actually what you needed to do was to say, can your health system roll it out in this way or that way? And, for that, you needed to think about the different populations and people where, as to what kind of way in which you might roll it out. So my feeling is that it is really important to be thinking about what the question is and who it's for. And surely it must first and foremost be for the populations, so I put an S on, where the trial is being done. I think, Rashida, your point, it's an interesting point about the standard of care. I remember, I suppose more than 25 years ago, I suppose now, when the first trial of preventing mother-to-child transmission came out, and that was the 076 trial. But of course, it cost $1,000, and you needed to give the drugs intravenously and all the rest of it. And a big working group set up to say, what other trials should we be doing? Now, if you compared everything to that standard of care, we wouldn't have got anywhere. That standard of care was not applicable to most parts of the world. You couldn't bring women in and give them an intravenous drip for however long, etc. And so actually other ways of thinking of that had to be done, but it caused an enormous row and lots of people resigned from the New England Journal. Some people still went out there and said, you've got to use the high income standard of care. And I don't agree with that personally. I think you have to think about what is relevant to that population. So that my thoughts about this is, what is the question and how do you then answer it? And it may involve a trial. I mean, I thought it was interesting what you were talking about, the rations trial, which actually, funnily enough, I know people want to repeat it, but how to repeat it? Because giving food can be done in many different ways. And they're talking about, well, shall we give RUSF, you know, one of these processed foods which aren't necessarily acceptable, or should we be doing it in a different way? And how do you answer that question? Because there you don't know whether giving extra baskets of food to families, how that might actually work in terms of reducing TB incidence, even if it does. So I haven't seen any hands up from the audience. Can we pick somebody, Gareth? Who's your best friend out there?
That's too mean. But I'm really hopeful that somebody will want to jump in and join us. But Rashida, over to you first.
Yeah, sorry. I think, Di, and I'll refer this to Seye, that I think you give an example of, well, you know, that IV stuff. I mean, that's a very particular example but there are, in fact, real life trials happening of things that are justified in terms of how we are going to do it or why, when there isn't a need. And an example, I'm reviewing a trial right now where we know that a particular in Nigeria, where vaccination coverage is really low, and incentivizing it. I mean, you know, you need to really think about where exploitation comes in. And the second thing is that we need to
sorry,
can I just finish, please? The architecture of global health is that a lot of these decisions about whether a trial should be done in an LMIC is decided by powerful forces in the global north who decide that this is available as a standard of care, or is this not, and we should move the science forward. And whilst many funders and grant applications talk about engagement, I'm not really sure that that engagement is, in fact, real engagement. And to add to that, I think it's really also important to consider the term generalizability, because we talk about this trial that will be generalizable with many public health interventions that absolutely speak to context, as you've said, Seye. And so, you know, those things absolutely need to be considered before doing a trial. And I just would like to, I guess, hear from, you know, well, the audience, or perhaps Seye, or with respect to those issues, because there are lots of trials happening today where the standard of care is considered different, and that decision is being made by people in high income settings.
Can we hear from Pawasha?
Hi, hello there. I'm currently in northern Pakistan, so I don't know if you can hear me. My internet.
We can hear you beautifully. Go ahead.
Oh, that's amazing. Okay. So really thank you so much, Seye, and also thank you, Rashida. And it was also really enlightening. Thank you. I think it's Professor Gibb, to hear your thoughts, because I mean, just that example of it's not the reality for many people of being able to give IV AZT. And I completely agree that, you know, it does need to be based in reality. But that kind of did make me feel that, do we not then perpetuate some form of epistemic justice in some ways, because of the fact that we kind of go, well, it's not available here. And it's just, for me, it's like, how do we use that to say, you know, there is a difference between high income and, you know, a lot of areas where a lot of researchers from the global north research And yeah, I just find it quite interesting because it's like for me a continuum, and for me it's almost like I think we should be using that to advocate and say this is so not, we need to be able to be providing a standard of care. But yes, budgets are not, but it's just for me, sometimes accepting a reality and not changing it is almost reinforcing what I now understand to be some form of epistemic injustice. So I don't know if that was.
Well, maybe I could just briefly answer that because I do agree with you, and it's about having a little bit of a crystal ball. Because I mean, things may not be affordable when you actually do it, and there is a pathway to make it more affordable if it is shown to work and then can be rolled out. And absolutely, you have to be aware of that as well. And the other thing I feel is really important and is to think about which again, ministries of health, etc., do have to think about the costs and the economic aspects of if they were going to roll something out. But having something which is clearly not going to be rollable out in particular settings, and doing it there in order to inform a part of the world where they're not doing the trial. In other words, it's got to benefit where you're doing the trial. I mean, that I think that goes without saying, and I think that's part of what you are saying. In that, if you and in fact, I mean, a lot of questions are relevant to globally, and actually having a trial that goes across the globe, literally, in terms of high income and low income. And Penta's been quite good at that. I mean, I was thinking about the Odyssey trial, and it also has a lot of benefits in terms of actually something being accepted across the north and the south. They may have different economic aspects of it, but that I think is a big plus if you're doing that sort of thing, because there is a tendency otherwise to say, that's not relevant to the north because it was done in Africa.
Okay, Seye, do you want to just make your point now? And I've got one other supplementary question as well.
Yeah, I think again there was a risk that I anticipated in what the discussion may look like, which include that we will talk about trials of things without being specific about those things. So, for example, that we can talk, for example, about a multi-country trial of a simple thing, and simple in the way that I described the range of complexity. The multi-country trial of a simple thing that makes sense. And that there's an audience for, and that there's a clearly theorizable pathway to uptake and rollout, etc. We can also talk about trials of things for which trials make no sense, but we do. In other words, things that are sufficiently complex that no matter how many parts of the world you put together in the trial, it's still not going to tell you anything worth going with in terms of effectiveness. And I think it's important to distinguish between these shades of things. Now, I'll end on this point. There was a point made earlier about another version of the rations trial. And I don't know what people are looking for. I don't know what is lost that needs to be found about the need to feed people. I don't know that thing that is lost.
Can I just ask you, Seye, because you did comment at one point about the role of ethics committees, and I'm aware actually Yahaya has just joined us from East Africa. It's difficult to know where to take your clinical trials sometimes to get an ethics approval that is appropriate and meaningful. Can you talk about that? Because obviously, as the editor of the journal, you have to interrogate investigators as to whether or not they've got appropriate research ethics approvals. What direction of travel is this going in? I mean, for colleagues setting up trials in with communities in LMIC settings, what's the right place? Because I'm certain that the Research Ethics Committee that I chair is not the right place to go to get an opinion about their the validity and ethical integrity of those studies.
I'm happy you said that because that raises the question that is on the table in a different way, which is if people in a place cannot sufficiently govern that which you've brought to them, then it is impossible to make the claim that they wanted it, will benefit from it, they desire it, they deserve it. In other words, often the challenge is that the question and the program is set in isolation from the people who need it. And it is not their question. They wouldn't know how to begin to reckon with all the things that have been brought. Now, unfortunately, those things are also brought with a lot of resources, jobs, careers, etc. That it cannot possibly pass any basic test of ethics. I was reading a paper just earlier today, and it was from a group of bioethicists who were saying, don't give financial incentive more than €100 for a study because they think it will overly influence the study. I'm like, come to Africa and come and see trials. Like you can't, what people are getting is more than €100. Right. And by the way, that's the €100 in the global north. But bring the €100, bring multiples of that, and put that on the table and say, should we do this trial or not? I will say do the trial. If in Nigeria, I will say bring the trial because it comes with money. It will feed some people. Do the trial. In other words, there's a lot about what we take for granted in terms of ethics that I don't think we are ready for this discussion in a serious way. We're not ready for this because if we are ready for this discussion, that would be like number 5 on the list of things we are going to need to be thinking about. One of which is why is this? Does this problem exist in the first place? And getting the engagement and the interest and the knowledge and the insight and the interpretation of the people there. It would mean reimagining the entire process itself. If we're going to get to that point 5 where we are doing ethics, we'd have had to do point 1, 2, 3, 4 completely differently for point 5 to make sense. And I don't think we are ready to think about what point 1 to 4 looking differently really means.
Thank you. And please, any other points that people would like to raise before we draw this to a close?
Yeah, if I may just ask one other question of Seye. So Seye, I mean, this builds a little bit on what I think Palvasha has written in the chat, is that many of these conversations are underpinned by the fact that the power structures and systems do not value humanity in the same way, and that what is acceptable and deemed worthy in the global north is not the same as for those in the global south, and made worse by the fact that decisions are not made by the very people who are going to be the populations at benefit, even though we try to convince ourselves that that is the case. So in that respect, one issue that I want to ask you about trials is when we do trials in the global south, a lot of the time we say, okay, that the drug will be made available or that intervention will be made available. And we write in our grant applications that, yes, we will do our best to engage so and so and so and so, when we intrinsically know that the health system may not be able to deliver that intervention should it be found effective or efficacious, as the case may be. And linked to that, it is very context. So even if you do, for example, hybrid 3 type trials and you build innovations in it, the evaluation is being done in the context of what is an artificial scenario, even though you may call it pragmatic, whatever, where you've got dedicated staff, etc., etc. And that is certainly not going to be real in what happens in real life. And every single trial I've seen, the outcomes when you apply it to real life are never as good as that in a trial context.
Yeah.
So I just wanted to hear your point about that bit, because, you know, that speaks to kind of the underlying epistemic injustice.
I think that there's a connection between that question and Gareth's question of ethics. And this is how I think about it. That if you and I can know ahead of a trial what will likely happen as a consequence of it, or what may not happen, will likely not happen, that it should be possible to hold one another to that. My preferred scenario is to have the equivalent of retraction watch. To those who don't know retraction watch, it's like a website that documents and details retractions and research integrity issues. To have an equivalent of that looks at pretty much a random sample of trials or studies done in the name of global health or health equity, and really analyze what the authors have chosen not to know in order to do the study, or what they have every reason to know, which if they knew, they will have no reason to do the study, and to hold people to that consistently, so that it then becomes what ethics committees ask for. Like if I was designing my scenario to change all of this, you need to have that kind of platform. Because for so very many studies that we do, we know people won't have access to these things. We know the people who won't have access to these things. We go ahead and do the studies pretending that they will have access to these things. And then they don't have access to the same things. And then we say, they don't have access to the things. We had wanted for them to have access, but they don't. But we knew from day one that they wouldn't. Etc. So we have to find ways of holding ourselves to higher standards than we currently do. And it would need for everyone, and now I'm preaching, I'm on a pulpit, it would need everyone in this audience and everywhere that, you know, to be willing to do that. Pick a study that should not have been done and really thoroughly explain why it should not have been done, and teach it in a classroom. Write a letter to an editor, write a commentary, invite yourself into an editorial, because we can stop this, because we know better. Often we don't want to admit that we do, but we know better, and we can hold ourselves to higher standards collectively.